for the conditions of compassion to flourish in us, among us, and in the very fabric of our organizations. So we take this time really pausing to acknowledge, all of you here today and all of the people beyond these four walls who dedicate their lives to service today and each and every day, and already demonstrate that compassionate presence in all that we do. So might this time here with Dr. Puchalski be a time to renew and reconnect to that intention and that commitment. So it really is an honor to welcome a world-renowned physician, pioneer, and international leader in the movement, a radical movement of love to integrate spirituality into healthcare settings, medical education, and just from the brief time I've had to spend with Dr. Puchalski, really, it's also going beyond. So we're honored to have you with us. So without further delay, please, your turn.
Okay, can everybody hear me? Yes? Okay, great. Let's just make this a little closer. Thank you so much for that beautiful introduction and for raising awareness to the sacred ground that we all stand on here today. It's very beautiful to refocus us to that and to continue that honoring. So today I'm going to share a little bit about some models that we've worked on to address spiritual distress and suffering with patients. And we know that spiritual distress is experienced by the people that we serve, our patients, their families. People use the word suffering or existential distress often. And it can be manifested in many, many different ways based on people's illnesses, age, whether they're religious or cultural beliefs or other beliefs, atheists, agnostics, et cetera, different customs. And we've been working over the last 20 years with many colleagues, including Betty Farrell. Some of you may know Betty Farrell is a leading nurse researcher in palliative care in the US. She developed the program called ELNIC, Educating Nurses on End-of-Life Care Curriculum, and she and I have partnered since 2004, doing a lot of this work, including some of the current work that I will be talking about. But our goal is really, and for me personally, it's seeing patients' suffering go unattended. Their pain may be addressed, their physical pain may be addressed, but I have so many stories of patients and families, and myself, my dad is 96, almost 97, and I've been the family member when he's been in hospitals, and I've seen our own suffering get unattended, as well as that of many of my patients when they go into different types of clinical settings. So I was really touched by the initiative that you have in your healthcare system here to talk about compassionate presence, to train, to be aware, to be present in the moment to patients. And I will share a little bit of what we've done in two arenas. Tomorrow, and I think later today, I'll talk a little bit more about presence itself, but also how we can begin to talk with our patients, open up the conversation to be able to hear their suffering, to enable them to put some words on their suffering and how we can treat them. So this is from Google. It's not my patient, but it's an image of one of my patients, of many of my patients actually, but the one I'm going to talk to you today about, and just tell her story a little bit now, and then throughout my presentation, give you some models, and then show how this might be, quote, written up in an assessment treatment plan in a very maybe reductionistic way, but a way that I have found very helpful for myself and for physicians and nurses and other colleagues. We work in those kinds of models, and we want to make this accessible so you don't have to have a degree to do generalist spiritual care, and I'll talk a little bit about the difference with that. You don't need to have a huge training in generalist spiritual care. You need a little bit. We need the training like we have consistent with our professional training in clinical care, whether as doctors, nurses, social workers, psychologists, OT, PT, et cetera. And we need additional training to know how to ask these questions, but we don't need a degree in theology. We don't need a degree in chaplaincy, and I'll show you this. So this is a patient of mine in my supportive and palliative care clinic. I'm an internist. I also work in geriatrics, and I'm a palliative care specialist. And I run a clinic in supportive and palliative care in oncology. We have an interprofessional team, including a board-certified chaplain or spiritual care professional. So this was a patient new to us in the clinic who, when she presented in this picture, is not exactly the way she looked. She was in severe pain. Metastatic breast cancer with metastases to her hip, where she had a pathologic fracture. So her primary concerns were her physical pain and all that goes with that, fatigue and inability to sleep, inability to walk, inability to function, not able to have her grandchild bounce on her lap, all the things that are important to her. So in our visit with her, we did do a spiritual history. And I'll do a little bit more of how that came out later, but she initially said that everything was fine. She's spiritual, it's important to her, she has a great faith community, and everything is just totally fine between me and God. So I remember thinking, there's something else in this story. Maybe she's fine with her and God, but there's something else. And so I asked her, and I'll talk a little bit about doing a spiritual review of systems, I asked her if she ever felt any despair or hopelessness. And that was all I needed to ask, because then she shared the most profound, and I don't think I've ever witnessed such profound suffering. And it was interesting because as she was sharing her suffering, her daughter was behind the wheelchair. And the daughter was very attentive throughout all of the visit, but as the mom started sharing this suffering, and even the chaplain next to me, later we debriefed it, the chaplain was so tempted to comfort right away because it was very hard to hear. The daughter pulled out her cell phone and started working on her cell phone as her mother was saying, and nobody really knows how to listen to me when I'm in this place. I mean, I wish I could have taken a picture. It would have been totally rude and inappropriate, but the picture is in my mind. It was just exactly what she was talking about. I just want to be heard. So I'll tell you a little bit more as what happened to her and her journey with us in the clinic and also her illness journey. But when we think about suffering with patients, particularly facing serious and chronic illness, there's many different aspects. This is just a little list, but meaning is a huge one. I'm not the person I used to be. My life no longer has meaning. I used to be able to do this, and this gave me meaning. I can't do that anymore. If people believe in God, I'm not sure I really believe in God anymore. That used to give me meaning. It doesn't. So that is a huge question for many people. Hope, being able to tap into sources of hope. And of course, in the midst of deep suffering, it's impossible to do that. It takes time. This is not something we clinicians can fix. I have to say, as good as I am at presence, the other day I was talking to a very good friend of mine, and her husband's very, very ill and now on dialysis. And she said something like, and the dialysis unit looks like some MASH unit. It's horrible. And I started to say, and I stopped myself, I started to right away think, but I know some places where they live in California and Beverly Hills that are better. I started to say that, and I stopped myself. And she laughed, and she goes, I'm glad you controlled that fix-it doctor in you. Because that's what we want to do, right? We want to help. We want to fix. But this is not something we can use those similar resources that we use in other settings with patients. Mystery, the why me, why now is perhaps, I've learned this from chaplains, the most common distress that we hear in patients. Why me, why now? Why me, why now? What is it going to be like for me remaining whatever time I have left, if that's what people are dealing with? Or if they're in the curative phase, can I be cured, but can I deal with all of this side effect of the medication? Isolation, many people feel isolated. That patient felt very isolated. And I felt that isolation as I also saw her daughter doing exactly what she said. And helplessness, we all want to have control. This is a big thing, but we don't really have control. A patient of mine once, a brilliant man who was dying of Parkinson's, said he was really upset about something, and I said about not being in control, because he had always been in control in his professional life. And he said, he goes, no, I'm not in control, but I'm having to let go of my illusion that I can be in control. It really strikes me. So that was that sense of helplessness he was going through at that time. There's many, many studies now coming out around spiritual, religious, and/or existential distress. They measure it in many different ways. And as you can see from this study, there's studies out of the US, there's studies out of Switzerland, I believe in this country too, I didn't find any for this particular slide, HIV/AIDS in Brazil, in Zimbabwe, huge number of patients experiencing spiritual distress. So it's what I think of as a global pandemic. And I thought of that title because I was at another meeting where a good friend and colleague of mine talked about the global pandemic of pain. And this is a meeting for palliative care and for making the case that palliative care needs to be in all countries, and how many parts of the world do not have adequate opioids, which is absolutely true, and we absolutely need to fix that. But I also thought about then, well, what about spiritual distress? We need to also care for that. But it's not just about palliative care and end of life. One of my colleagues, a new colleague in Europe, is doing a lot of work on domains of whole health. And her impetus is to try to expand on the World Health Organization definition of health, which I'll show in a few slides. And in her coming up with trying to do a definition, she had many focus groups and consensus conferences and things like that. And what she came up with, and what was interesting, because I gave a presentation at the same conference as she did, and she said, oh, it's so great that there's someone else using the word spiritual. And her coming from a very different, no palliative care, this is more from well-being and total health. So the domains, as you can see, are very similar actually to the domains of palliative care: physical, social, spiritual, and existential, financial, and intellectual. So they've been working on these domains and coming up with definitions in each of those domains. And then in the biopsychosocial spiritual model, we have all of the domains, the physical domain, which many of you are obviously familiar with, psychological, social, and then also the spiritual, which includes many of the items that I will later talk to you about, some of the diagnoses or concerns that have been developed around spirituality. So in terms of the World Health Organization definition of health from 1948, it's the complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So two things are missing there: spiritual well-being. Many people have tried to get that word in. And also, can people have health but still have disease and infirmity? And that's what Margaret Hubner was working on. This was her passion. As we are getting older in the world, as more and more people are getting older, they're not going to have strict physical health, right? They're not going to be in an absence of disease or infirmity. So what is health for today in the world? And so this is her proposed definition from 2004. Health is the ability to adapt and to self-manage. Health is the ability to adapt and self-manage. And through her focus groups, she came out with these three main points: the ability to perform relative to the condition. So how people can function with arthritis, with other conditions, but still function to a way that gives them meaning and ability for them. Achieve individual fulfillment, meaning, and purpose, and so that's the spiritual domain. And then negotiate the demands of the social environments. So I think this is a wonderful, now has WHO adopted this formally? No, but this is a work in progress. I wanted to share that also. And then in terms of definitions of spirituality, a lot of our work, and I'm going to focus on a consensus conference we did in the US, but we also did one in Geneva with a more global audience. And so we took a definition that was accepted in the US and really worked with this global group, with them, as to what they think is really important in different cultures. So what was interesting too is that this was in Europe and held in Europe. People from many different countries were there. But many of the people, many people from the Europe are probably more, maybe similar. We had Canadians there as well, where it wasn't so religious focused. In fact, there was a strong secular presence. And I found this very interesting with that background. So they added dynamic and intrinsic. Felt that was really important. It's not static. It continues through life, and how we experience the moment, whatever that may be, in illness, in health, with each other, in strife, whatever, that our spirituality is going to be evolving and changing. But what I really thought was interesting is we had dropped in the US ultimate meaning, because that sounded too religious, and transcendence, because it's too philosophical, right, for the US crowd. So they added that back in. And I didn't tell them we dropped that, actually. That was just something that came out of the work in that group. Persons seek ultimate meaning, purpose, and transcendence. And then rather than connectedness to others, it was the experience of relationship to our inner self, family, others, community, society. Society was a strong word that came out of the Australian community, to honor the indigenous societies, as they call it there, nature and the significant or sacred. And then the research group there, Shane Sinclair, who will be with us tomorrow, was part of that research group. And many of the good researchers in Europe, Australia, New Zealand, Canada were in that group. They stood up and said, that is really hard. That first part is really hard to study. So can we add spiritualities expressed to beliefs, values, traditions, and practices? So that was a very enlightening process. The group, they decided to forego a fancy dinner to work through this through dinner. So we had dinner in the room as we really took this seriously as to what is a definition. So I understood some of you have been using this definition. So the purpose of spending this much time on a definition is, in my experience in the US, since the early 90s working in this, there's been a lot of resistance to the word spiritual because many people immediately equate it with religion, and then all of how they perceive the negative aspects of religion. They don't recognize the positive aspects of religion, but the sort of the political, how can I say this, some of the political aspects of particular religious groups. And so people aren't comfortable with that. They're nervous about the word spiritual. So why we didn't want to go through enormous amounts of arguments and work on this, we felt it was important to bring people together who were both religious, of all groups, as well as secular, to come up with a definition that everybody could live with. And this is what I think is so beautiful about this. It's a dynamic, intrinsic aspect of humanity in which people seek meaning and purpose, and how we experience relationship to the significant or sacred, however we understand that. So I think that's a key piece. And I talked to someone earlier who said that here you talk about spiritual and secular as being equally important. So I think that's the significant and sacred encompasses both of those arenas. Eric Casal has talked about this in his writings on ethics and how we can come to understand the dimension of meaning and purpose in people's lives. But he talked about the transcendent dimension, and in it he said, everybody has a transcendent dimension, a life of the spirit. The quality of being greater and more lasting than an individual life gives this aspect of the person its timeless dimension. The profession of medicine appears to ignore the human spirit. When I see patients in nursing homes who have become only bodies, I wonder whether it is not their transcendent dimension that they have lost. You know, in his writings, and in much of my experience and many of my colleagues, and Betty Farrell has written a lot on this from the nursing perspective, as have others, it's that notion of our systems not allowing that transcendent dimension of the human person, the spirit, to be visible in our clinical systems. And I think it sounds very different here, but in general, it's very, very focused. This was back in the early 1900s. Physicians were in charge of the body, and the religious and everybody else, they took care of everything else. And so we've developed, and it's not just in the US, we've developed this profession of attention to the physical domain. But he's written, and I will show you that I think all of these domains are in our responsibility. So Kathleen Dowling Singh wrote a beautiful book called Grace in Dying. And in it, this is a quote from her, in dying we move from chaos to surrender to eventual transcendence. Initial encounter with illness and the prospect of dying can result in chaos. Surrender is when one is open to one's deeper being. Transcendence is going deeper into spiritual integration. And I think I've been drawn to that statement for many, many reasons. I have a contemplative heritage in more of the mystical aspects of Catholicism, so it spoke to me very much. This also is something that comes out of many religious traditions, Buddhism and secular traditions as well. But this notion that think about if you were to be given a very serious diagnosis, or your loved one just died, or something tragic just happened, life is chaos. And part of that is staying in that chaos. The patient I mentioned, it was chaos for her at that first visit. So we can't move people through this with a pill, nor with one visit. This is a journey that the person takes. But this is where accompaniment is so critical. We accompany people on this journey. And I'll talk a little bit about where people may be stuck a little bit in this movement to surrender. And that's where I think spiritual distress may develop, and where we may need even more professional spiritual care providers to help our patients. So triggers, I've just talked about them. There are many triggers for this spiritual journey. And it can be aging, it can be serious illness, chronic illness, stress, life changes, etc. So how is it that spiritual, religious, cultural beliefs can impact a patient in the clinical setting? Well, it impacts their understanding of illness, how people understand their illness. And I'm sure here and in many places, we teach our medical students and our nursing students, how does the person understand the diagnosis that you just talked to them about? What is their understanding of illness? Rita Sharon's work on narrative medicine is not just about their whole story, but what is their story in the context of this illness now? How does it impact decision-making? Some of the obvious things about advanced directives, living wills, use of pain meds, level of alertness, various choices about health. It might impact who might be the spirit support person or people or their decision maker. And it might be in people's lives the culturally based healer or their clergy or their significant other or their teacher or spiritual care professional. So we need to be thinking about that as to who is on the team. It impacts other treatment choices in terms of their spiritual life, medication use, CAM, prayer, spiritual practices, etc. It might impact a treatment plan, certainly and always, and I do use the word chaplain. We use that in the United States. We are moving to spiritual care professional. I use that interchangeably, but I do understand that there's a Christian-Jewish context with the word chaplain. So spiritual care professional referral, meditation, yoga, et cetera, and then it impacts how people cope. So coping, resiliency, connection to God or the other, the transcendent other, however people understand that, finding meaning. This notion of being comfortable with mystery, letting go of control, that's the surrender aspect, finding support. It might even help them reframe. They have to do the reframing themselves. We can't reframe for them, but it might help people, patients, reframe death or suffering. It might offer a different way of having control. Sometimes people find turning things over to a higher power or a God or some sort of philosophical concept a way to be able to let go of some of that control. And so, as I mentioned before, spiritual distress can occur when people can't experience. Now, everybody can experience this. Many people may be able to get through that on their own, but many may not. So where they experience and cannot resolve the loss of dignity, meaninglessness, hopelessness, or despair, feeling of that loss of control, and a conflict between deeply held beliefs and values and their illness. So taking that beautiful quote about spiritual growth, I tried to think about how to frame this with my medical students. If we put the person in the middle who's going through all of that, my patient sitting in that wheelchair in total despair, sometimes people can move to spiritual growth. I don't want to say on their own, because I don't think people are on their own, but they can move through that either with companionship from significant others or their own resources, but sometimes not. And that's that spiritual distress. And that's what I'm talking about, that everybody on the team needs to address that. So it's not just what's your pain on a scale of 1 to 10, so what's your spiritual distress today on a scale of 1 to 10? I don't even think that works well for pain. I see some people laughing because you can't do that for spiritual issues. And actually now the 1 to 10 is under great criticism because of the opioid abuse too, that was not used correctly, but anyway. So it's a discernment process. So I can't quickly in 5 seconds diagnose where my patient's gonna be or not. So it's a discernment process, but it's not one that we clinicians, the non-chaplain, non-spiritual care clinicians do on our own. This is where it is so critical that we work with spiritual care professionals, because they have training in faith and spiritual development. They have training when there's crises in different stages in people's lives. They have deep training in that. And they have training that we don't, the rest of us don't have. And they're able to work with us to help us know where that person is and what we can do for that person, especially in spiritual distress. So meaning in the midst of suffering, we all talk about it. Viktor Frankl wrote about it beautifully from his experiences in a concentration camp during World War II, and then later in working with people as a psychiatrist, working with people who survived those camps. And he wrote about how people who could find meaning in the midst of suffering were able to survive that. His work, if you know Bill Breitbart and meaning-oriented therapy, Bill was very moved by his work and started, I think, in the 70s, this research around meaning-oriented therapy, which is built on the therapy that Viktor Frankl did. So, it takes time to find that. Some people can do that, as I said, and some people, we need additional ways to be able to help them. So how can spirituality then help a person heal? I think this is the area of the human person in which healing may occur. Cure might occur in the physical domain, but healing in a different sort of definition, I think, occurs in the spiritual domain. And that is where I have seen incredibly healed people shortly before they're dying. And this is what's so great about palliative care, because it's the focus that healing continues all the way through, and that our living, our dying, a term that we discussed last night, is a way in which that can happen. The openness to the mystery of what can happen in those final stages is some of that. So this part, which I'm not going to talk too much about, because that I believe it's very strong in your system anyway. I'll talk about that more. But this notion of our witnessing to a person's suffering. If you have ever experienced deep suffering, you know that words you can't put it into words. And then as I almost cut my friend off as she was sharing the suffering of her husband, perhaps nearing his end of life, as I almost cut her off and I didn't, and kept my mouth shut and listened. People have to struggle through that and move through that. So that witnessing, it's in partnership between us and our patients and their families. But it's not us actually doing or fixing. It's us walking that journey, walking on the road. The patient is the one that makes the turns, and we accompany them. We don't make the turns for them, and that's what's so key. So, being grand rounds, and it's important to have data, and even, for all of us, regardless of your professions, all of our professions, there is an important need for having research in this area for credibility and for other things, and that includes research for spiritual care professionals as well, for all of the interventions that we do. We are far from intervention studies, but I'm going to share one in particular that I really like, and there's more that are happening now. But initially in this area, there were association studies, so people who are religious or people who are spiritual have certain outcomes that are different from people that score lower on these various indices. And we can have lots of discussions on whether those indices really reflect the totality of spirituality. They don't, but it's beginning work. So spiritual well-being, which is the broader definition of spirituality, does affect health-related quality of life. There's an improvement. People who have high spiritual well-being tend to have high quality of life. There's improved coping. Interesting studies I think in India that show that people who have a higher degree of spirituality as measured on these surveys tend to have a greater awareness of their own prognosis and a willingness to talk about that. They're more at ease with decision making. They're not struggling with it as much. Carla Ripamonti, who's in Italy, she's an oncologist. She looked again at spiritual indices in patients, and those that have a greater spirituality tend to have increased hope and greater meaning in life in her cancer population. And then George Fichette, Fitchett. I really strongly recommend his work. He is a chaplain and a PhD he's Quaker, chaplain, PhD in epidemiology, and is running a very popular program now in the U.S. called Transforming Chaplaincy, where young chaplains are learning to get master's degrees and PhDs and do research. And it's very important to have chaplain, spiritual care professional voices in research around spirituality, obviously. So this is important. So this is a meta-analysis that he did. And what he found out looking at these 101 studies, that greater religiosity or spiritual well-being, so both of those, tend to result in better health, less depression, less anxiety, and greater social well-being. People in terms of needs, so looking at in hospitalized patients, people who felt that their spiritual needs in the hospital system were not being met, gave lower ratings of quality of care. Conversely, people who felt their spiritual needs were met had higher patient satisfaction. So that's another area of important research. And then also work in children. I'm not going to talk too much about children, but there's a lot of work done on spirituality in children and their coping. And later today, I'm going to talk a little bit about different stages, including with children, and how chaplains work with children in their relative to their stages. Tons of studies. This is but one up from Tracy Balboni in Cancer. Tons of study looking at the importance of spirituality in patients in the U.S., and now they're in other countries as well, where the majority of patients say this is really important to me. And then this was a study, again, from Astor and Macy. They developed a spiritual needs subscale. I don't know if you can really see that. I guess you can. But you can see the different subscales around spiritual needs in a diverse population of cancer patients, finding meaning, finding hope, overcoming fears, personal meditation or prayer practices, relationship with God, becoming closer to spiritual community, coping with suffering, meaning and purpose of human life, finding peace, resolving old disputes, forgiveness, making ethical decisions around care. So very interesting study coming out of that group. So one of the first intervention studies, Betty Farrell did this out of her group at City of Hope Cancer Center in Los Angeles. And again, she's an incredibly well-known qualitative researcher in cancer and palliative care. So they looked at 491 patients with lung cancer, and they specifically looked at an interdisciplinary palliative care intervention. And this was an intervention in which patients and families had 4 educational sessions. In the experimental group, the 4th session was on spiritual issues. In the control group, it was just more on social and other issues, not spiritual. So the group that went through that, the experimental group, had less depression, less anxiety after that, improved spiritual well-being, and improved patient experience as well. So since then, I don't have that study, but I've become aware of a study that's about to be published for chronic pain management that has very similar outcomes. So it's beginning to look like, but again, this is very beginning, that outcomes of an intervention that specifically targets spirituality, maybe less depression, less anxiety, improved quality of life, and quality of life measures spiritual well-being. So I wanted you to see the City of Hope Quality of Life instrument, where it measures the 4 domains, and the spiritual well-being domain is meaning, uncertainty, hope, religiosity, transcendence, and then a positive change. So in addition to the research, we all have ethical standards on attending to suffering. So this is another making the case for this. Even though, when I was first starting to do this, and even now, there's still some criticism that the research is not the gold standard, a clinically controlled trial. Betty comes close to that. Betty's study now does. But so if you don't, in those days I was saying, well, it's putting the research on hold here for a minute. It is our obligation to attend to suffering. And American Medical Association stated that, American College of Physicians, World Health Organization palliative care resolution that I worked on states that, 2014, a National Consensus Project, NQF states that, the European Association of Palliative Care Goals states that, and I'm sure you all have various, in your education and other places, various guidelines that suggest the same thing. So in the World Health Palliative Care Resolution, which was a major event for 2 reasons. One is that leaders since 1982 in palliative care were trying to get the WHO to pass this. So 1982 to 2014, things take a long time, and that's okay. But the second is that finally the word spiritual appears somewhere in the WHO documentation. And it was not easy. It was not easy. I was involved in that. I can tell you it was not easy. There was a lot of struggle for many different reasons, particularly since the impetus of doing this resolution was to make sure that there's adequate pain management resources for people globally and adequate palliative care resources to develop palliative care teams. But because palliative care has this whole person model, it was a natural transition to get buy-in for this. So it's the definition of treatment of pain and other problems, whether physical, psychosocial, or spiritual. And look at that second one. And this is, I didn't realize it until I've been talking about it more and more, but it's the ethical responsibility of health systems. I would say your health system is fulfilling this based on the compassionate work you're doing. It's the ethical responsibility of health systems, and it's the duty of us professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual. What does it mean to have a system? It's an ethical responsibility to have a system, right? So this is key, and it's key for many reasons. And then, of course, the last bullet, while they weren't quite ready to say spiritual care professional, they did say spiritual care, support care providers, including spiritual support and counseling, which opens the door of that. And one of the reasons is most places in the world are not as lucky as we are here in the US, in Australia, New Zealand, and Europe to have a formal spiritual care professional. But that's changing. So I want to talk about a 2009 paper briefly, or a project that I did with Betty Farrell. We did publish it in a book, Making Healthcare Whole. This was built on the National Consensus Project Guidelines in palliative care that defined the 8 domains of care. And prior to this, which was, I think, 2003 or 4, there was no separate spiritual domain. It was, I believe, under social or psychological. But it was pulled out as required, so spiritual, religious, and existential aspects, and the only recommendation was everybody should have a spiritual assessment, but it didn't say how, who, what, where, and how, and what to do with it. So then Betty and I brought together leaders, it was over 40 national leaders representing physicians, nurses, chaplains, or spiritual care professionals, clergy, non-healthcare chaplains, clergy, psychologists, social workers, and other spiritual care providers, included pastoral counselors, spiritual directors, faith community nurses, and healthcare administrators. So we had a very diverse group. We did this consensus-based definition, and then we made recommendations. This was in February of 2009, and then identifying resources to advance the quality of spiritual care. So just to give you perspective, so this was 2009. We started a lot of the work in the early 90s, and it's just a really great program that just came out that's building on this. So things do take time. So I always tell people, just get into it, just start it. It'll happen over time. So it's an integrated model, and I'm going to skip down to the generalist specialist. I want to highlight that first. So we talk about a generalist specialist model with regard to spiritual care. And I'll talk a little bit about what that means. So I'm a generalist. Spiritual care professionals are the experts, so the professionals. And it is much the same as I'm also a general internal medicine physician. I can work on cardiac issues. I can do some emotional work, but I'm not a psychiatrist nor a counselor. I'm not an interventional cardiologist, so I know when I need to refer. It's that type of a model. It's based on honoring dignity, attending to suffering. Harvey Chachnoff was part of this group. Spiritual distress is treated the same as any other medical problem. Many people are working on it as a vital sign. And again, it's interdisciplinary, includes spiritual care professionals. Really, really key. And I think in the language about spiritual care professionals, we can have more discussions this afternoon about that, but there are differences between healthcare chaplains, pastoral counselors, spiritual directors, and clergy. And it's important to recognize the training for each of those is different, and when to refer to them is also different. So everybody gets a screening history or screening, and then we have this whole person treatment plan. So a lot of my work, as I hinted at or stated at the beginning, is working with my colleagues, which were mostly very reductionistic physicians, as I am too. I mean, I really enjoy, I love assessment and diagnoses, but how to do that and at the same time address a person's spiritual issues without having to have a philosophical or theological degree. So it's developing this assessment and diagnosis and treatment of spiritual distress, and integrate that in symptom management, that we have to attend to suffering and identify spiritual resources. I talked about general specialists. Now this is an important bullet, provision of compassionate care. I think you guys are really ahead here in this organization on that. But when I started this work, to mention presence, that was maybe worse than the word spiritual. Like, whoa, Christina, that is so theological, presence. We don't want to go there. So now that mindfulness and other things are becoming more popular, people are willing to put their toes into this a little bit. But it has taken a while. But the very first step, I say to you now, is to provide compassionate care. That's the first step in this. But I'm going to share more some of these other tools of how to open up to those conversations. Because even in being compassionate and being present to someone, hopefully in our deep moments of depth and contemplation with our patients, their suffering might come out, but it might not. And so identifying this is critical. So it's a very, like I said, reductionistic model that we did, which is upon entry to a system, when people get screenings of other types, they should get a spiritual screening. The goal of that being is if someone's in serious spiritual distress, they need an immediate referral to spiritual care professional. That we then, the rest of us, meet people on the team, those of us that deal with developing treatment or care plans, which are usually advanced practice nurses and physicians and PAs, NPs, et cetera, would do the history. And then the spiritual assessment that has BCC, that's called a board certified chaplain. I have a big move and a requirement for healthcare chaplains to be board certified, healthcare spiritual care professionals to be board certified. They do a much more intense spiritual assessment that's narrative and is also outcome-based. I should say that's a work in progress, but it is. And then we have an interdisciplinary team. Ideally, the chaplain is there as well, or a spiritual care professional, that we integrate it into the treatment plan. We measure outcomes. So if I identify spiritual distress at the follow-up visit, I follow up on that. I don't just say I've addressed it and that's the end of it. I ask where people are, and it's important that we do that. The dotted line is the transformative interaction, and we're going to talk about that more actually tomorrow when we do presence a little bit later on today. But it's really the professional preparation and personal preparation, which I believe your compassion training programs here address. What do we do for ourselves to be able to engage in these relationships with our patients? So the non-chaplain clinicians, we address spiritual issues in care, identify distress, incorporate spiritual distress and assessment and plan, and support resources of strength. And we work with trained spiritual care professionals, as well as others on the team. So the National Cancer Comprehensive Network in 2007 developed spiritual distress diagnoses. Then they called them chaplaincy diagnoses. They have since changed to spiritual distress. So the rest of us can use some of this. We are far from coding for this. We have a V code that we can code if we spend time on this. But this is, as I said, a work in progress. But most of the chaplaincy departments actually have this list up in their office. So they know how to communicate to the healthcare professionals. They can communicate in our language, right? This is about language. I because of my background, I can sit down with a chaplain and really get presence. And I admire it so much, and I've learned from chaplains. But, this communication and these kinds of models is essential to help the patient. So this is very busy, but I'm just going to say it very, very simply. We all do a distress assessment, and we need to think about where that distress is coming from. This is how I teach the medical students and the residents. Is it physical? Is it emotional or psychological? Is it spiritual? Is it social? One or two of those combinations, what is it? And then who do we have on the team to best help us address all the total needs of the patients? So we also have, and some of my chaplain colleagues in the US called it a simple spiritual issue. And every time I say it, I take a breath because there's nothing like that. But I know what they meant, and we've left it in the paper. The simple is one that, and this is where I don't think it's simple, we can be present to our patients. We can accompany them. We can do a history. We can try to understand where people are coming. We can ask deeper questions. We've all been trained in that. So and then maybe with our presence, it does resolve over time, but maybe not. And if it doesn't, we need to do a spiritual care professional referral. Or if it's complex from the beginning, we obviously have to do a spiritual care referral. This is just to say that the American Academy of Pediatrics, this is my, remembering Joan Marston. I don't know how many of you know her, but she ran the International Association of Palliative Care and Pediatrics. And the two of us are very close friends because in the resolution, when I was saying spiritual and she was saying kids, we emailed to each other privately saying, so this is our role. She's the NAG for pediatrics and I'm the NAG for spirituality. So in her honor, I put this in here, that in fact we are doing things with children. Our colleagues colleagues who do work with kids, it's really critical to address spiritual distress in children. And there's some beautiful ways. There's a chaplain at Children's Hospital in DC that has great methods and ways to recognize spiritual distress from infants on up, and what chaplaincy does, spiritual care does to handle that. So there are different types of assessment. I mentioned screening. We developed a FICA tool which is validated at the City of Hope. There's also Spirit and Hope tools for history, and then the assessment, again, that is done by the chaplain. And it is expected that the detailed evaluation done by the board-certified chaplain, spiritual care professional, they identify needs, distress if presence, resources of strength as well, and they develop a spiritual care plan that's got expected outcomes and is communicated to the rest of us on the team and tell us what we can do. This is the FICA tool. It's really was developed with a group of primary care physicians, and it's now been used with many other groups, nurses as well. And we have integrated it into some training programs, and it is integrated in our school and in many medical schools now. But it's an opening question about whether the patient considers themselves spiritual or religious, what that means to them. Sometimes the person will say no. We ask, regardless of whether they agree with the word spiritual or relate to that, we still ask what gives your life meaning. Listen to the importance of that in their life. Listen to the impact, or ask their impact on health. My patients love that, because many times they say back to me, I never thought that my spirituality might impact me in my health. So then they think about it, and we continue to have that conversation. We ask about communities. Can be church, temple, mosque, like-minded friends. Family is often the number one community for people. Yoga group, other support systems, cultural systems, etc. And then A used to be permission. How would you like me to address this area with you? But now with the assessment, we put that in as the assessment part. There was a study done by my colleagues at Palliative Care at NIH, National Institutes of Health, and they did a quality improvement project to encourage their clinicians to use it in order to establish that trusting patient-clinician relationship. And initially, when they taught the palliative care fellows, the fellows had a hard time doing it. So they did another intervention where they actually had the fellows and the spiritual care professionals go together and do this. And then the fellows could do it on their own. And at the end of that particular intervention, the number of completed histories and consults to chaplaincy doubled. And this is a beautiful definition of spiritual care out of the NHS in Scotland. And I think this is what we all do, to different degrees within our expertise. That care which recognizes and responds to the need of the human spirit when faced with trauma, ill health, or sadness, and can include the need for meaning, self-worth, to express oneself, for faith support, perhaps rites or prayers or sacrament, or simply, again that word, for the sensitive listener. Spiritual care begins with encouraging human contact and compassionate relationship, and moves in whatever direction needs require. And this is from the spiritual care professionals, but I like to share this with the clinicians as well. Generalist specialist model, I've already gone into that. Just to explain, just to share a little bit of, in the US standards, this care is provided by board certified chaplain or spiritual care professional or a student in a CP accredited, by the way, very important, accredited clinical pastoral education program. And examples of care include emotional, spiritual, religious, pastoral, ethical, and or existential care. So we've had to ban or try to ban the perception that chaplains only or spiritual care professions only do religious care. It's beyond that. So the training is clinical pastoral education, a master's of divinity, or the equivalent. So we have chaplains from various backgrounds, including secular humanist chaplains. They're spiritual experts on the team. They facilitate family team meetings, support the others on the team, and they do the more in-depth spiritual counseling or working with patients and families. They can confirm or change our diagnosis of spiritual distress, and I know that's a little controversial with the theological groups, but and they certainly are trained in reflective listening and identifying themes. They have a number of interventions that they do, and there are more and more studies coming out, particularly in the US, testing the intervention of chaplains. One of those interventions I understand here is dignity therapy, but there are many others that chaplains do that is within their scope of training, in their CP training, et cetera. Presence is a huge one. and then writing up the assessment and making recommendations for us. So I'm going to close with this. The patient that I brought up, we teach our students to do a complete history, including a social history. Full disclosure, we do have huge problems in the US with healthcare of moving people through. There was a Facebook post that healthcare is not like a McDonald's where volume matters and rapid processing matters. We don't do that, should not do that in healthcare, but we have those stresses. So I know even with the social history, sometimes it's ended up being do you smoke, drink, or take drugs. But we do teach to a real social history to find out who that person is, and in that is a spiritual history. So this was my patient that was that pathologic fracture. She has a life partner with and 2 children that are 42 and 47. I talked about her pain. But this is a woman that's been active all her life, and she assumed that now that they both retired, she and her partner, they would travel the world. They knew each other since high school. They would travel the world. And so she felt sad about her life being cut short. She did, even though she said things are okay with God, and this was a real lesson for me. Because when I interpreted things are okay with God, I immediately thought she's despairing, how can they be? And I was so totally wrong. So she was very angry at God, but she said to me, my relationship with him is so good that I can actually be angry with him. And it's really good because I unload on him all of this stuff. That was in a second conversation. So it was very interesting for me to learn that. But in the end, she said, it's basically why me? And, it was a real, working with her and having the chaplain work with her was really powerful. There were a lot of questions about surgery for the hip. It was very aggressive. It actually worked, and she's doing really well now. So Methodist Church is important. Praying is helping her, and that first time she talked about prayers, about my anger with him. Her faith has always helped her. Very strong community, but she did not really want to burden them. So part of her not finding listening people was that she felt she would be a burden, and there was a lot that the chaplain actually recognized with that and helped her. She was afraid at first to share her anger with her pastor, but she was delighted to be able and safe to be able to do that with a spiritual care professional on the team. Pain was very high, emotionally sad, not depressed, but anxious about this surgery decision. Good supports, but nobody, as I said, to talk to. And then the anger at God, which in the end I thought was a resource, but that was one issue, fear of uncertainty, a lot of existential distress. What is going to happen to my life, my meaning, and despair? So we did the usual thing that teams can do. We elicited her story, were very present to her, explored, not right away, you can't explore hope right away, but in time explored hope and meaning. The chaplain was with us on the team, so I didn't have to make a referral, but she continued to work with her. And then inviting family. So this is much more was written in the note, but this is what I could put up on the slide. When we think about an assessment and plan, this is what I tell my medical students actually to do with everybody, not just people who are seriously ill. But what are we doing for her physical well-being? What are we doing for her emotional, her social, and then spiritual counseling with the spiritual care professional on our team, eventually exploring sources of hope. And I really enjoyed learning from her about her faith and what that meant to her and what that relationship meant to her and continues to mean to her. The chaplain, she gave the patient permission to be angry with God in that sense of being able to talk about it a lot more. That didn't happen in the first visit. It was after her visits with the chaplain that the patient was able to articulate that more. She helped her articulate her despair and loneliness. She explored potential guilt and perceptions, so a lot of guilt about what she's doing with her family. That didn't come up with my conversation, but it did come up with the chaplain. She participated in the family meeting, the chaplain did, the spiritual care professional did, and really was great at helping her empower her voice. As an aside, Cynthia, who's the chaplain, really is helping me do that too, because especially at the beginning, I was so used to my ritual of what I ask patients, and Cynthia would bounce in when she would hear something relevant. And at first I thought, oh my God, I'm gonna lose track of what I'm doing. But now I've come to really like that because it broadens my perspective. So the social worker and the nurse also, we broaden each other's perspectives. I'm gonna skip that, except for to say that this was a person, so that it can be a non-religious issue too. And this is a patient of mine, she has since passed away, but she was diagnosed with Alzheimer's. big on nature, photographer, loves cats, her 2 cats and my 2 cats. We used to share pictures, and very frail and doesn't like the way she is. And she didn't like the diagnosis of dementia and thought the Alzheimer's was wrong. And in fact, she was right. He was wrong. She had a different type of a dementia, but not Alzheimer's, and she did very well. Her spiritual history, meaning in people and relationship, doing good, a huge advocate for animals' rights. Also, her intellect was really important to her, and that was partly what was causing her distress. It's very important. It's the core of who I am. No spiritual practices. She dabbled in meditation and yoga, but nothing particular. And her community were those like-minded friends, her animal advocacy groups. They were great people. Because they could also advocate for her. So when when she was in the hospital, they were enormously good people. So I did the usual thing with review of systems. Her concern was impairment that may affect her ability to do what's meaningful. Some of the aspects of what we at the team did, the team, and in that case, I did not have a chaplain right there. She did work. I referred her to a chaplain who works in an outpatient setting, and that person helped her look at what doing good work means and what would it mean in her context now, which was then. Listen to some themes of spiritual connection, which certainly was her community. Explored her fears about not being able to do good, and explored ways that she could do well. So just want to end with that. The whole aspect around spiritual care is basically rooted in compassionate care. But until we actually address spiritual issues, we're missing a big part of that compassionate care. And it's being present, listening to the whole story. And as the Dalai Lama did in a foreword for a book I did, he wrote a beautiful foreword, and this was part of it, where he said, real care of the sick does not begin with costly procedures, but with the simple gifts of affection, love, and concern. And that's what we're about. Thank you so much for your attention.
Thank you, Christina. And I know our time is elapsed, and I would just, we may not have time for questions, but I would really like to invite Shanine Lane, who is the coordinator of spiritual care education here at St. Boniface Hospital, to say a few words of thanks.
Well, so on behalf of everybody here and those in our telehealth world, wherever they may be right now, I just want to say a huge thank you. It is an honor to meet you and to have you here speaking with us. I teach a lot of your stuff in the education that I do, and I appreciate that you've helped us return to compassion, to meaning, to purpose, to spiritual distress, and that you've really raised my own awareness. Although I know this stuff, it's a very great, helpful reminder, and to see it in a larger context has been very appreciative. So on behalf of us all, thank you so much, Dr. Pahalski, for coming and for sharing with us your wisdom, and we look forward to hearing more from you as we move forward. Thank you so much.
So before we go, just a note that Dr. Puhalski's book is available for sale just outside the doors here. And there's still space if you care to join us for this afternoon's workshop or tomorrow's one-day session. Just simply come to the St. Boniface Cathedral lower level and we'll sign you up. And Julie wanted me to let you know, if you are signed up, regarding parking. Parking is available in the St. Boniface Hospital parking lot, and also the 2-hour ban has been lifted on the Cathedral Street. So with that said, maybe we have time for just a question or two. So please, if you care to, there's a mic here, or maybe someone from telehealth.
Thank you very much for your presentation. I'm just curious whether or not our chaplains are board certified or whether there's any kind of certification process. And I don't know if anyone could answer that for me.
I believe yes. I believe from the Canadian Association for Spiritual Care, right? That there is board certification. In fact, I'm almost certain of that because I work with our groups in the U.S. and we often do work together. So.
And I think it's important, Judith Birch is here from the province, the Provincial Spiritual Healthcare Coordinator, and we've been doing a lot of work to update our core competencies, and there's clear qualifications that underlie the importance of certifications. So that's an important piece for people to recognize. So, and that information is available on the Manitoba Health Knowledge Network, so mhiknet.ca, and you should be able to access that information.
So I'm
Or
curious,
kind
how
of
many
spiritual healthcare.
spiritual care professionals are there here? Yay! Wow, that's great. Look at that. Look at how many people are here. I just want to add to that little history. In the U.S., that was a huge piece of how can I say, advancing spiritual care profession in the U.S. because you know, chaplains are equal members of the healthcare team. And so all of us on the healthcare team have standards and qualifications. And I remember Joe Driscoll, who used to be the executive director of the National Association of Catholic Chaplains, once said, you wouldn't hire a physician who has no license or certification. Why would you hire someone that doesn't? And that caused a lot of conflict because people were still doing beautiful work, but it's about being within a system and meeting the kinds of training and continuing education that I think is important, especially when we're working with patients. So I just want to put that out there for that.
Thank you very much for your grand round speech here. I'm a registered nurse, and I work in St. Boniface Hospital here. And I guess, like, I very much identify with this work and it being brought forward. I work in hemodialysis, so we're not officially palliative care, but we deal with a lot of end of life, a lot of displaced people, a lot of very vulnerable people. And I witness on a very frequent basis a lack. And I guess my question is, or challenge for us is how can, in the area I work in or the other areas, how do we get more visibility? Like, I know spiritual health exists and I do my best to offer it up to my individual patients as I can. But what I want is culture shift, and what are some steps that we can start taking to bring it forward, right? Because I'm already on board, but you know, the other 60 nurses that I'm not working with, that I work with, right? They're not all here today, or right? And different people, as they learn different things, slowly get on board. But how can, like, for example, say I have a patient who is expressing the desire to end treatment. The first place often that they go to is a referral to psychiatry, as opposed to perhaps maybe a spiritual health practitioner would be a more appropriate starting point, because maybe it's not actually mental illness that, or
I
kind
know.
of thing.
That may be a very healthy decision. Yeah, but
So I guess that's just kind of my question / challenge / whatever.
Yeah.
That's just kind of bubbling up for me.
Well, thank you for your work, because yes, I think the work you do is palliative care at its best. I mean, you know, with people are on dialysis, it's a life-limiting, but also there is deep suffering. So thank you so much for your presence to the patients there. Yeah. So how to do this? There are various ways. You're already doing some of it. So I think role modeling, trying to put in a question or two on, I don't know what forms you have there for intake. Those are ways to begin to do it. We actually, what I'm going to talk about more, we've started a program called the ISPEC, Interprofessional Spiritual Care Education Curriculum. That's a train the trainer. So we have an online course. It's very similar to Betty Farrell's ELNIC, if any of you are familiar with that. That's because she and I are collaborators on that. So it's inviting spiritual care clinician pairs to a training together to build leadership in whatever area they're in. So actually this year's program this summer is already overfilled. It's going to be a challenge to fill everyone in, but we do actually have an application that's from a dialysis unit, which is great. Okay, so that's a little bit more, that the online is like a level 1, and then the train the trainer is to build leadership. And I very specifically wanted to be spiritual care clinician pairs, and to try to build leadership in different areas. And it doesn't have to be like a huge involved program. It can be simple, like start with a question, do some training around that. I think the presence is a huge piece of it that you have already. So that's, 1 foot up. But I think asking about it, teaching your colleagues about spiritual distress. And I am 100% on board with you that any question regarding discontinuation of treatment or, any question around end-of-life care, there should be an automatic consideration, in my opinion, of a palliative care team, which should have a chaplain, a palliative care chaplain. So absolutely, I agree, because those are more existential spiritual questions. And yes, I mean, many of our chaplains know how to assess, most of them know how to assess if a person is depressed or not. I always do. I think we have to do that, but the clinician should be able to do that. And then, work on the spiritual issues. Yeah.
Great, thank you.
Thank you.
Well, I'm glad that we made some space for those questions and reflections, and just wish we had more time. But if you're able to join us for the next day and a half, please do so. And perhaps this is not the last of relationship with Dr. Pohalski. So thank you all for your presence, and until soon.
Did you get a picture for my dad? Oh, great.